But things are never black and white. It's not, when we write guidelines, we like to be pragmatics for easy implementation. In fact, if you look at the evidence, so this data, really good paper, IPD, meta-analysis, large number, what it highlighted is actually, number one, the cervix, the length of the cervix varies with gestational age, but also the diagnostic accuracy and the cutoff, the best cutoff to predict preterm birth in twins varies with gestational age. So a cervix that measured at 18 weeks is different from a cervix that measured at 24 weeks in terms of the predictive accuracy. And also the predictive accuracy, the performance varies according to the cutoff of the preterm birth. So was a preterm birth less than 28 weeks, was it less than 32 weeks, less than 34 weeks. So really, one size doesn't fit all. But for easy implementation and for guidelines, 25 millimeter. The other thing is that whether is it actually useful to do repeat assessment or repeat measurements? And again, that's some of the questions that were posted in the chat. Hence, I decided that we will have the discussion afterwards because some of them are addressed in this talk. And most of the guidelines, certainly NICE in the UK, does make it clear it's a single cervical length assessment. But this really nice study from Canada, where they did longitudinal cervical length assessment in twin pregnancies, and they identified 4 patterns. You see here the red, which is early rapid shortening of the cervix, the green, which is a cervix that's stable with gestational age, the yellow, which is stable to start with, and then late shortening, and then the blue, which is early shortening, and then plateau. And what the figure on the right-hand side here showed that this different pattern of the cervical length, the longitudinal changes in cervical length, have different risk of preterm birth for various cutoffs. So there's a 36, there's a 74, 32 weeks. But as you would expect, of course, the red column had the highest risk among the 4 groups, compared the green one had the lowest risk. What about twin pregnancies that are symptomatic? And I think, again, Conrado covered that. So women who present with abdominal pain, for example, and to the triage. Is cervical length a good screening tool in these pregnancies? And the answer is no. And this is, again, the same meta-analysis. And you see here the positive likelihood ratio, the negative likelihood ratio, they're very low. And therefore, it's a poor predictor, really, of the risk of spontaneous preterm birth with various cutoffs. What about biomarkers, things like fibronectin? And we published this paper last year where we looked at the literature, and this is a long list of the biomarkers that have been studied over the years in terms of their association with the risk of preterm birth. And of course, the top of the list is fetal fibronectin, but it's all associated. They're not very good predictors on their own. And therefore, at the moment, none of the published guidelines recommend them in women or twin pregnancies symptomatic for preterm birth. The other thing which I would like to highlight, which is something that's happening in the UK at the moment, I don't know whether it's the same in other countries, but certainly in the UK, we have supply disruption for fetal fibronectin, and that's from NHS England in the UK, where they issued a warning about the fact that it's not available, and at the moment we're looking at alternatives. If you notice, this was December 2022, but actually also recently there has been a similar problem with the supply of fibronectin. So that's about screening. What about in prevention? And I'm going to try to avoid repeating or duplication of the evidence on progesterone, because Fabrizio has very elegantly covered that. But what about bed rest? Because still nowadays people do recommend bed rest in whether twins or singleton pregnancies. And just to really to highlight this Cochrane review, which is clearly the conclusion is the fact whether it's strict or partial, whether you have bed rest in the hospital or at home, there's no really evidence that it has any beneficial effect in women with twin pregnancies with various cutoffs, for the various cutoffs of preterm birth. What about the oral beta mimetic? Again, similarly, there is a Cochrane review clearly that actually there is no really evidence that giving prophylactic oral beta mimetics is useful to reduce the risk of preterm birth in women with twin pregnancies. For the progesterone, and again, whenever you look at prevention, look at the women in unselected, so giving it to all twin pregnancies, or twin pregnancies with additional risk factors like short cervix. And again, I think I'm not going to go through that in detail, because that Fabrizio covered that when he actually did clearly state that actually do not give progesterone to all twin pregnancies because it's not beneficial. And if anything, this meta-analysis showed that it's potentially harmful. So this is the relative risk. This is a 95% confidence interval. And if this 95% confidence interval does not include 1, it means it's significant. And relative risk of 1.6 means those who had progesterone had 60% higher risk of perinatal death compared to those who did not have progesterone. And therefore, clearly, it's not beneficial. And if anything, it potentially harmful, increased risk of perinatal death, respiratory distress syndrome, and composite adverse outcomes. What about in twin pregnancies with short cervix? And again, I'm going to sort of skip that quickly because Fabrizio covered that. He covered IBD meta-analysis on the role of progesterone in twin pregnancies with short cervix. And this is pioneering work by Professor Romero. And that was sort of highlighting really the potential beneficial effect of progesterone. He also mentioned about the trial that was conducted, and the highlighted obviously that there is potential maybe question to actually this recommendation, and the updated meta-analysis, including the REHAL study or the events study. And this is also the recommendation was still that actually giving progesterone to women with twin pregnancies that have short cervix reduce the risk of preterm birth. And if you see, this is something called the forest plot. This is how you report meta-analysis. And you combine the data together, 0.6 relative risk means about 40% reduction of the risk of preterm birth. And it's not just preterm birth, but also composite neonatal mortality and morbidity. So certainly the evidence does support giving progesterone in women with twin pregnancies with short cervix. Okay, well, where is the controversy here, Asma? Well, the controversy is the fact that if you look at actually the recommendation by professional societies, actually there is variation. Not all of them do recommend giving progesterone. Here, for example, the French do not recommend giving progesterone. The American did not make a recommendation. German societies and the Canadian Society did recommend giving progesterone. ISWAG in the previous version, we did recommend progesterone. Updated guideline, we still do recommend giving progesterone. And again, just to highlight that NICE, in the most recent update, April 2024, did recommend giving progesterone to women with twin pregnancies with short cervix. Interestingly, actually, they said with twin or triplet pregnancies, which is interestingly because the evidence in triple pregnancies is actually really scarce. But it seems that having pragmatic approach, they did recommend progesterone also to women with triple pregnancies with short cervix. What about this consensus that we did recently? And again, to some extent, there is consensus by 78% of the people that we should give vaginal progesterone to twin pregnancies with short cervix. What about cerclage? And for cerclage, we're going to look at two groups, the women who have short cervix and the women who have dilated cervix. So this IPT meta-analysis combining data from 3 studies, so twin pregnancies with short cervix, the recommendation is the fact that it wasn't significant. So you see that the forest plot, the diamond crosses the 95% confidence interval, crosses the line of 1, means no difference. And therefore, based on that, the recommendation is don't give or do not recommend cerclage to twin pregnancies with a short cervix. What about dilated cervix? Well, women who have whether singleton or twin pregnancies that present with a cervical dilatation in the 2nd trimester, they tend to have really poor outcome. So the risk of preterm birth less than 32 weeks or less than 28 weeks is about 90%. We all come across these patients, majority of them will deliver early. And it's not just that, but the risk of perinatal mortality is also high, 50 to 60%. So can we do something about it? Well, this randomized controlled trial, small one, was published in American Journal about 2 or 3 years ago. And this is a randomized twin pregnancies that have cervical dilatation between 1 and 4 centimeters that present prior to 24 weeks. And they randomize them to either the cerclage or expectant management. And just to highlight, the group that had the cerclage also had antibiotics and had indomethacin. You see in only 17 pregnancies in the cerclage and 13 pregnancies in the expectant arm. So really small study. The initial plan was to have more patients, but the trial was stopped early because actually the interim analysis was significant to the extent that it was probably unethical to continue to randomize patients. So they stopped early and they published the results. The results is actually quite fantastic, is the fact that the women who had the cerclage had significantly lower risk of preterm birth with various cutoffs, 34, 32, 30. So the preterm birth less than 24 weeks, relative risk of 30.35 means 65% reduction in the group that had the cerclage. And it's, you can argue, so what? I mean, it's not what we really care is mortality and morbidity, not just reducing the risk of preterm birth. But if you see this trial, the perinatal mortality, 18% in the group that had the cerclage, 77% in the group that had expectant management. So almost 80% reduction in the risk of perinatal mortality in the group that had cerclage. And therefore, I mean, based on this randomized controlled trial, it's a small one, but based on this, I think there is robust evidence, level 1 evidence that does recommend offering what we call emergency cerclage to twin pregnancies presenting with cervical dilatation in the second trimester. What about the guidelines? Well, the guidelines, if you see consistently, they do not recommend cerclage in twin pregnancies. The ISWAG and FIGO did highlight the potential role of emergency cerclage, which is different from elective cerclage. So what's the latest evidence on cervical cerclage in twin pregnancies with short cervix or dilated cervix? So we published this meta-analysis last year in PLOS Medicine. And in this meta-analysis, what we did is that we combined the data from all the published studies and we did sensitivity analysis. So we did pulled the data from the randomized control trials separately and from the observational studies separately. And when you combine the data, all the studies, you see that actually there is a reduction in the risk of preterm birth less than 34 weeks in the group that have cerclage. 0.73 means about 30% reduction. But actually, if you look at the evidence from the observational studies, and if you pull the data together, there's about 500 pregnancies in the group that had the cerclage, about 375 in the group that had no cerclage, again, significant reduction. But if you combine the data just from the randomized control trials, there was no significant reduction. This diamond crosses a line of 1 or there's no difference. And we also looked at the risk of perinatal loss or composite adverse outcomes, and this is for women who have short cervix, defined as less than 15 millimeter, or cervical dilatation. And again, you see that the results were significant. There is a reduction in the risk of perinatal loss or composite adverse outcomes. So what about the consensus or the C-Twins project? Again, there was a consensus that we should be offering cerclage to twin pregnancies presenting with a dilated cervix. So nearly 80% supported that. But in women with twin pregnancies with short cervix, there was no consensus. And you can see, so 63% said yes if the cervix is 10 millimeter or less, 62% if the cervix is 5 millimeter or less, but there was no consensus. So it's an area where really there's controversies. There is some sort of, in this project, and I'm not going to share all the findings, there was really some granular question about whether if you're going to do the cerclage, do you do it when the cervix is 5 centimeter, fully dilated, 7 centimeter, 2 centimeter? And again, there was a consensus about 5 centimeters. So maximum cervical dilatation is 5 centimeters. And what about if the membrane is bulging or not? Because some would say if the membrane is already prolapsed in the vagina, maybe we should not put a cerclage. Again, the consensus was that yes, if it's technically feasible. Whether you do amniocentesis or not, there was no consensus that it's routinely, you should sort of routinely offer amniocentesis, but if you would do it for the presenting twin. I did mention earlier that the randomized control trial of the cerclage for twin pregnancies presenting with dilated cervix, also in the group that had the cerclage, had antibiotics as well as indomethacin. And again, there was a consensus that if we would do the cerclage, that we should offer antibiotics and also offer indomethacin. The final intervention that I'm going to show you the evidence or so the controversies about the pessary, the cervical pessary, and it's very controversial. But again, if you look at the pessary in women with unselected twin pregnancies or women with a short cervix, and the meta-analysis does not support that it does have any favorable effect on reducing the risk of preterm birth. You see here the 95% confidence interval includes one, which means there's no significant difference. And in women with a short cervix, this is the Stop It 2 trial, which was multi-center, it's probably the largest trial of pessary in twin pregnancies that was done in the UK, and the trial was negative. And what they did when they published the paper, they combined the data from the randomized controlled trials with data from other randomized controlled trials. And the controversies lie is the fact some of the trials showed beneficial effect of actually the pessary in twin pregnancies with short cervix. So the Goya from Spain and Liam from the Netherlands, both of them showed significant reduction in risk of preterm birth. But the Nicolaides from the UK was again, I think also had other centers, Bergella, and the Stop It 2 trial from the UK did not find any significant beneficial effect. And therefore, when you combine or you pull the data from all the trials, the results were not significant. So what about the recommendations by various professional societies? Well, actually, almost all of them do not recommend the cervical pessary. I think the German Society did recommend cervical pessary in twin pregnancies. What about the consensus or the Delphi? Again, there was consensus that we should not offer cervical pessary in twin pregnancies with short cervix. 80% voted for the fact that we should not recommend it. What about in women with twin-to-twin transfusion syndrome that had laser surgery? And again, just to show you the controversial evidence from observational studies and from randomized controlled trials, the two really good papers published in the American Journal last year. So if you see here, this is a study, 2 centers, where they looked at the impact of offering pessary to women with TTTS, had laser, and have short cervix. And the results of this observational study was promising. It actually showed that doing or giving the pessary to women who have TTTS, had laser surgery, and have short cervix is beneficial. You reduce or was associated with a reduction in the double neonatal demise by nearly 80%. The adjusted odds ratio 0.2 means about 80%. And in fact, if you look at to define which group was most likely to benefit from the intervention, was mainly in women who have cervical lengths between 5 and 18 millimeter. The same journal published the results of the randomized controlled trial of the pessary in twin pregnancies with TTTS that had laser surgery. This randomized controlled trial was stopped early, so they were supposed to randomize 364. They stopped after 137 women for futility. They randomized about 70 women in each arm. So one arm had the Arab pessary, the other arm had conservative management. And you see that the primary outcome was preterm birth less than 32 weeks. And you see there's no difference between the two groups. So 40% in the pessary group, 36% in the conservative management group. Therefore, the conclusion, you have a TTTS, you have laser surgery, have short cervix, do not routinely recommend the pessary because there's no evidence that it does reduce the risk of preterm birth for 32 weeks. The final part of my talk is about steroids, and I added it because it's so topical and it's so controversial. And because we have so many questions that we don't really have robust evidence to address. So whether you give steroids in twin pregnancies at the gestation, late gestation, so after 34 weeks or not, what different gestation age windows, if you're going to give steroids, what will be the interval from the delivery? Do you give dexamethasone? Do you give betamethasone? Do you give the same doses, the singleton, or do you give different dose in twins? Does it differ according to chronicity or different complications in twin pregnancies like selective fetal constriction? And just to highlight that we have, so we managed to get funding from the NIHR, and they gave us about 2.2 million to do this trial, which is called Stop It 3 trial, which is randomizing twin pregnancies at 35 to 38 weeks plus 6 days to either steroids or placebo within 7 days of the delivery. The primary outcome needing respiratory support within 72 hours of birth. We have a list of secondary outcomes, including obviously the cognitive and language development at the age of 2. So controversies related to preterm birth, I could carry on for another hour, but I'm going to stop here and see, hopefully Eva would be able to share her screen. Eva, are you still with us? Okay, I'm not sure. Eva, are you able to share your screen for your talk?
Yeah, I'm here. But you need to make it off. So you have to do something so I can share.
I'll host now, so you'll be able to share.
There we are.
Perfect.
Yep. Yeah, I think you can see my screen now.
Yeah, perfect.
Sorry, I was in an unstable Wi-Fi, so that I'm somewhere in the basement. So I hope I will make this through. Good afternoon, everyone. Thank you very much for your patience. I'm here to present the data of our quadruple P study, which is a randomized controlled trial, and I'll take you through it. So there was funding by our own foundation, but they had no influence on the design or execution. It was registered, a trial in the Dutch trial registry. It had medical ethical approval. And we have one disclosure. So this is the twin trial. Maybe you know our singleton trial. We published this year. It was published in the BMJ, and just for those who are interested, there is a QR code, so you can scan it. It will also be at the end of this presentation. So we have gone through most of the background. I think it's the most used line in literature on preterm birth, that it's the most important problem in obstetric care. Progesterone is accepted treatment for cervical length less than 25 millimeters. And the pessary, I've seen a lot of questions coming by, what should we do with the pessary? So, and in the initial trials, it seemed to be affected. Asma already reflected on that, but there were very varying results. So we decided, this was already in 2014, to start an RCT. So it took us a long time to complete this trial. And there was no RCT comparing head-to-head, progesterone with pessary. So that was the main objective of this trial. And why did we want to do that? Already, as Asma said, there was a Dutch RCT, and they looked at the effectiveness of pessary versus expected management in twins. They didn't look at cervical length at all. They just randomized twins either to pessary or expected management. They didn't find any difference in the women with pessary or expected. It was the same. The outcome was the same. However, in a post hoc analysis, they saw that in the lowest quartile of the cervical length, which was then 37 millimeters, there was less preterm birth. So the hypothesis was that in women with a twin pregnancy and with a short cervical length, a pessary would have an effect on preterm birth rate. And as we see, it was almost half for preterm birth below 32 weeks. And it was reduced even further for preterm birth before 28 weeks. So this is why for our study, we chose a cervical length of 37 millimeters in case you're wondering where that came from. So what we did, and the other, to be honest, the other reason why we took 37 millimeters, because we thought then we can sort of, after we finish the trial, we can sort of filter it. We can see the effect on 25 millimeters or lower than 30 millimeters, because the question then is, I also heard the first speaker saying that the cutoff of 25 maybe shouldn't be the cutoff, and maybe we should go to 30. So that is always the discussion. If it works for 25 millimeters, will it work for 30? Will it work for 35? So that's why we opted for a slightly higher cutoff. So, and the aim of the trial was to compare the effectiveness of cervical pessary to vaginal progesterone in the prevention of adverse perinatal outcome associated with preterm birth in asymptomatic women with a mid-trimester short cervix and a multiple pregnancy. This was a multi-center randomized control trial. It was open label. It was a superiority trial, so we indeed tried to prove that pessary was better than progesterone, and it was performed in 20 hospitals in the Netherlands. The inclusion criteria were multiple pregnancies, both bichorionic and monochorionic, not monochorionic. So monobichorionic and not monochorionic, and an asymptomatic cervical length below 37 millimeters, and the cervix had to be measured between 16 and 22 weeks gestational age. Exclusion criteria were previous spontaneous preterm birth before 34 weeks, any signs of contraction, infection, or PPROM, anomalies, in cases with already a cerclage, when the cervical length was below 2 millimeters or there was dilatation, and the mom had to be more or less older than 18 years. So what did we do? We performed a scan in all those women. We measured the cervical length. If the cervical length was below 37 millimeters, all women were counseled and had to sign an informed consent before they were randomized in a one-to-one ratio, stratified per center for either vaginal progesterone, and we gave 200 milligrams per day, or an Arabin pessary. The primary outcome was a composite adverse perinatal outcome, which included fetal perinatal death or severe perinatal morbidity. The secondary outcomes were spontaneous preterm birth before 28, 32, 34, and 37 weeks, obstetric maternal outcomes. We had a predefined subgroup analysis for very short cervix below 25 millimeters. We also had a predefined subgroup analysis for on-obstetric history and chorionicity. The analysis was by intention to treat, and the outcome variables were assessed with rates, relative ratios, and 95% confidence intervals adjusted for intervention and center. And we calculated the sample size at 332 women, and we hypothesized that we would have a reduction of 50% in the composite outcome. And now we go for the results. So this trial ran between 2014 and 2023. In September 2023, following a DSMB advice, we decided to halt the inclusions as the fourth interim analysis. In the fourth interim analysis, there were 237 inclusions. The DSMB argued that they stopped for futility, and they said we would never ever be able to prove that pessary was superior to progesterone. So when we stopped, we had randomized 276 patients, which 138 in the cervical pessary group and 138 in the vaginal progesterone group. In both arms, several patients were removed from the trial. As you see here, for informed consent missing, there was no cervical length within the indicated time period. Some had an initial treatment with progesterone, and some women withdrew informed consent. And then, so we had 133 women in the intention to treat analysis for cervical pessary, and we had 129 women in the vaginal progesterone group. And of course, we had more children. And it doesn't add up because in some of them, there were also triplets. So that's why you think it's not times 2. It doesn't make sense. There's several triplets in there. So if we look at the baseline characteristics, maternal age was normally distributed the same as BMI. We have a predominantly white population, but since the area where we live in, we had also quite a large proportion of Black women and Middle Eastern women. As you see, there were 7% in both groups for women with a history of cervical surgery, and a large proportion had a uterine anomaly. If we look at the obstetric characteristics, we had more than half were nulliparous women. Some of them had multiparous women had a preterm birth, but not an early preterm birth, because that was exclusion criterion. There was in 10% a history of curettage, about 10% IVF. So about a quarter of them were monochorionic pregnancies. We had about 2 to 3% of triplets. There were no quadruplets or quintets in this study, only triplets. And the age of randomization was more or less the same. Had the same cervical length at randomization. And as you see, there were the only difference is that there were slightly more very short cervixes in the group that were assigned for pessary. And funneling was also more or less the same. Oh, sorry. Yeah. And now for the results. Our composite adverse perinatal outcome was not significant. It was almost 20% in the pessary group and 13.7% in the progesterone group. But as you see, it is not significant. And this is what we looked at, perinatal mortality. This is included in the composite. So perinatal mortality is more or less the same as are all the other, in none of the other outcomes, there is a difference. If we look at ruptured membranes or genital tract infection, chorioamnionitis, the use of cerclage in this pregnancy, vaginal discharge or vaginal blood loss, is all the same. The only difference is that there was more excessive discharge as reported by the women themselves in the pessary group. If we look at spontaneous preterm birth, then we also see no differences in those groups. It's more or less the same over the whole, even before 28 weeks, we don't see any benefits from the pessary. So the composite outcome for cervical length below 25 millimeters, the only thing is that progesterone favors more or less, if you look at obstetric history, only favors more or less the nulliparous group, but otherwise it's equal. Conclusion: in asymptomatic women with a multiple pregnancy and a mid-trimester short cervix, a pessary does not improve pregnancy outcomes compared to progesterone. And this is the end of my talk. Thank you very much. And these are all the participating hospitals. And this is our study group, so our project group. Sorry, and here's one more. Is the QR code for the for our paper in the BMJ. But that's on Singleton. This one's not yet published. It's coming. Thank you.
Fantastic. That was brilliant, Eva. Thank you so much. And it just shows a huge amount of effort to have these randomized control trials. And you can see the duration. And of course, in the middle, you had the COVID-19 pandemic. So, congratulations for actually completing and getting that far. And really sort of, I mean, I know it's negative results, but actually it's fantastic that we have this evidence, it's level 1 evidence, and it's not just comparing intervention versus placebo versus expected management, it's actually comparing intervention versus others, so pessary versus progesterone. So that was brilliant. Thank you so much. Fantastic. Well done. So I'm gonna start the discussion. I'm gonna invite Stephanie Ernest, our amazing PPI, who is kindly joined us today for the webinar. And just maybe if I can get you to stop sharing your screen, and then we bring the speakers of the panelists and the discussants. And then we have so many questions from the various people attending. So which is cheaper, progesterone for 20 weeks or a pessary? Well, that's an interesting question. Arash, do you want to take that, Eva? So
yeah, they're both very cheap. Actually, I don't know, but I don't think that should be a consideration at all, because in our country, progesterone is a couple of euros per pill or something, and it's fully funded by the insurance. And an Arab pessary is also cheap. So I would not give an Arab pessary, but not because I wouldn't look at costs.
Yeah. So Conrado, can I bring you? I think you got your hands. Oh, yeah. Do you want to say
Yes,
something?
now, just to say that I have made this calculation here for Brazil. Unfortunately, in Brazil, progesterone nor pessary, they are not provided by the government. The patient has to buy each option. And I have made the same calculation, and the cost is similar between 20 weeks of progesterone and one cervical pessary.
Great. I mean, I guess, so for that, I mean, I worked with NICE, and the way they look at the evidence, they look at, first of all, is the intervention effective? And if it's effective, they look at the health economics. Of course, by definition, if it's not effective, you don't. Would they actually compare the cost of various interventions? Not traditionally, because actually most of the studies will look at intervention versus routine care or expectant management or placebos. There are very, very few trials actually compared to intervention. So that's why I'm congratulating Eva, because it's not easy to do this trial. So well done. Okay, there's another question from Dr. El Shinawi. 21 weeks twins, dizygotic, I guess, or dichronic, expulsion of one fetus at 19 weeks. Is cerclage is mandatory? She's on progesterone, mild placenta abruption. Now to support the management, please. I wonder the difference. Oh gosh, that's an interesting case. I don't think we covered this one in this talk and in this webinar, which is someone who delivered one twin. So we said do not automatically deliver the second twin, but would you put a cerclage? I wouldn't put a cerclage in this pregnancy. Not necessarily, obviously, if she's bleeding heavily, you would deliver, but if she's not bleeding, no signs of infection, she's not contracting, I think it's very reasonable to do expectant management. I would definitely keep her in a hospital because of obviously the risk that she delivered the second twin, but I wouldn't put a cerclage. So it'd be interesting to see what Conrado and Eva would do. Would you do anything differently?
Yes, in my whole life, I have seen this attempt to conserve a second pregnancy 3 or 4 times only, and it never happened, never worked. So usually what we see is the second delivery soon after the first one. But for sure, I wouldn't put a cerclage, and I would be really expectant and consult the patient about it.
Yeah, Eva, I see you nodding. So
Yeah, I'm nodding. I would never put in a cerclage, and I have also not seen in these very extreme preterm births. It usually never works because the interval you need to overlap is so large, and in the meantime, the woman will get an infection. And putting in a cerclage, I think, is even contraindicated more or less because the risk of infection is so high. And if you look at maybe doing it after 24 weeks, I would also do expected management. And sometimes you're successful by delaying a couple of days. But everything before 24 weeks, I'm very skeptical.
Yeah, absolutely. There's one comment about the actin Bartus. I mean, I did mention about the fibronectin, and actually, I mean, fibronectin, yes, potentially useful as a rule out rather than rule in test, but again, the evidence in twins is not as much as in singletons. As I mentioned, in the UK, we don't really have sort of, there's an issue with the supply.
There's not even, and even in the Netherlands, they're just not making it anymore.
Yeah. Yeah, I think they had it with a quality control, as far as I understood.
I don't know, but we're also looking for alternatives. So it's not. It's a more broader problem than just the UK.
Yeah, and do you have actin Bartus?
Yeah, we do, and we're now actually in the middle of deciding which one we're going to use. So we don't have an answer yet because this is like very recent, but we are now discussing which one because the thing with fibronectin was that it had a very good negative predictive value. So it wasn't very good in predicting who was going to deliver. It was very good at predicting who was not going to deliver, which is also very helpful because you can send those people home. I think it was in your presentation, Conrad, with the cervix between 15 and 30 millimeter. We actually do exactly the same. And when the fibronectin was negative, we would actually let those women go home. So yeah, we have a problem there because we need to find something else for the intermediate cervical length group.
Yeah. Stephanie, I think you got your hands up. I think you want to say something.
I do. Actually, I was just going to say, back in 2013, I was actually one of the Arab and Pessary trial patients. I had a cervix of 2.5 millimeters. Not the question I have, but I just wanted to throw that in. But yeah, I really want to throw to the panel, perhaps. From the patient's perspective, I want to ask about how you counsel these patients, both short and long term. Like, what are the ways that you're doing it? Maybe people can drop in the comments as well what they feel. But for me, like, I think the way that research and everything like that is evolving, patients are now wanting to know not only what happens in the short term, but the long term. So I'm interested to find out what the perspectives are of the panel.
Oh, that's a really good question, Stephanie. I mean, the progesterone data, for example, there is long-term follow-up of these babies because progesterone's been around for years and many children have been exposed. It's a common medication that's used in IVF pregnancy, so exposure really early in pregnancy. I think there is good quality data on its safety long-term. The risk of actually the babies themselves, I think, is mainly really determined by the risk of prematurity. And therefore, I guess you would assume if you have an intervention that potentially reduces the risk of preterm birth, you would assume that it has hopefully beneficial effect in terms of the long-term neurodevelopmental outcome. Steroids, where I mentioned just literally a couple of slides at the end because it's extremely controversial and very topical. I think there is a huge controversial evidence on both sides about the steroid likely to maybe reduce the risk of the short-term outcomes, so respiratory morbidity, for example, but we have a huge question mark about the long-term outcome of these babies. Hence, we managed to get the Stop It 3 trial, which hopefully will look also. But when you say long-term, most of the studies will be 2-year long-term follow-up. Is that enough? Ideally, you want to have more, but very difficult, very challenging how to follow up, the funding to get to follow them up until 5 or 10 years.
Exactly. And I think here in the Netherlands, a lot of centers follow up preterm babies to 8 years of age. I know we were part of one of those studies, but yeah, I think what's really important is that we do actively start following these children up as well to find out more. But yeah, I'm really happy with that. But yeah, I'm interested if anyone else has an opinion.
Well, thank you, Eva. Or
Stephanie, we are actually doing a longer term follow-up of our children in both quadruple P trials, so both the singletons and the twins. It's always very difficult to get money for long-term follow-up because that's and then there is another issue, is the privacy issue, because it's you need to have so much consent. So if you didn't ask for consent to approach the parents later, which we didn't have when we started the trial, then we changed it. It's difficult. It's as if the EU regulations don't make it easier to follow up on children, because I apparently have a clinical relationship with the fetus, but once the fetus becomes a baby, I apparently don't have relationship with the baby anymore. So this is very conflicting, and we're trying our best, and we are doing it. Okay.
No, and my day job is actually working with clinical research and training for clinical research. So I know exactly the frustration where you're coming from. So yeah, it's kind of like GDPR killed a lot of things, but also that funding is such an important thing that we just can't get, and we can't get past this stereotype that prematurity ends at age 2 and that we need to follow these children up longer. So whether we can change the perception around that, it would be fabulous. But we can all dream, we can all advocate, and we can all hope.
Fantastic. I'm going to take a couple of other questions, and then we'll probably, we could carry on, and there's so many questions and comments. It's fantastic. And I'm extremely grateful to all the people who joined us for the webinars, whether the speakers and Stephanie, or whether actually the delegates themselves. Amazing questions and comments. But just about the 37mm cutoff that you chose, Eva, in your trial, you did actually justify, and I know you did mention the justification, but there's another question just highlighting, maybe reiterating why you chose 37mm as a cutoff.
The 37mm was the lowest 25% of another trial we did, where we compared pessary in all twins against expected management. And pessary didn't improve the preterm birth rate, so it didn't work. But then we looked whether it worked in the lowest 25%, and it seemed to work. There was a lot of discussion about this because it was a post hoc analysis and it was not predefined. That was the problem with it. But then when we were contemplating which cutoff to use, we knew 25mm was being used worldwide. But then we thought, what if we choose 25 and it works? And people are going to say, will it work in 26? Will it work in 27? Will it work in 30? Will it work in 35? So that was another reason why we decided to go a little bit higher, so we can sort of filter through it. And we did look at 25mm, and in our trial, pessary against progesterone does not make a difference. It's not better.
Yeah.
And even if you look at it, it's not significant. If it does something, the trend is towards its worth.
Yeah. Conrado, I think you have your hands up. You want to say something? Yeah, you're muted, I think. You need to unmute yourself.
Sorry. I would like to ask Eva if in this sample, the actual sample, 37mm was still the 25 percentile of this sample, of if now you have less patients with 35mm or less?
That's a very good question. We have a screening study. So but for the twins, they were mainly performed in hospitals. So we don't have the data on many twins. We only have those in our hospital. So I can't tell you whether it's the lowest 25 percentile. I can tell you in singletons, because we have a very large cohort, a screening cohort of singletons, but not for the twins. So I don't know.
Yeah. And I guess the same applies for,
I know why you're asking. I think you're asking because measurement of cervical length has become more and more important. And what we also noticed when we were looking at pictures, I don't know if it was you or the first speaker that also stressed how we should be measuring, and that it's now changing. And we are also looking at, because people are measuring way too long, especially when women peed like you went to the voided, sorry, maybe it's a better word, is they had like you measure the isthmus, and we would have patients filling in, or healthcare providers measuring cervix of 6 centimeters, 6.5 centimeters, and we're like, no, this is not possible. So there's going to be, I have it here, but we have addressed this also in a letter to the AOG MFM. And we also said that if you have the isthmus, you can use the peritoneum between the bladder and the uterus and as a reference point, but it's going to be published, and so it has my name on it with my PhD, and it's very interesting. So I think there is a way of measuring a cervix even when the woman has a contraction, and even if you see an isthmus, but you should be very, very careful. And I think that in the future, when more and more people are know how to do these measurements, we're going to have a slight increase in cervixes below 25 millimeters, because I think people have been measuring way too long.
Yeah.
Yeah,
So I
that
think
was the reason.
well, that really emphasized the fact that we need to ensure that when we train our healthcare professionals, ensure that the people who are doing it are competent in doing it. I think, Conrado, you spent some time in your talk emphasizing the technique of measuring cervical length. And I think the isthmus or the lower uterine segment is an issue more in the first trimester, when it's really sort of could be challenging to define the cervical length from the isthmus, but not really in the second trimester. I think if
Well, there is an amazing video I think a Spanish or Italian group that did like these little movies they made. Well, I can't show them now because I would have to look for it, but and they like scan like for 40 minutes, and then they show it quick, and you see the uterus contracting, and it's really amazing what it does. So you need patience and you need to know what you're doing. The problem is when the bladder is too full, you're going to have too long, the cervix will also enlarge. So you should really be careful there. So I think the recommendation to go to the restroom before your 20-week scan, and then at the end of the 20-week scan, perform the cervical length is probably a very good one. Because sometimes women come to these examinations and they said, yeah, they told me not to go to the toilet. So they haven't been for the whole day and their bladder is so full that it's also not a very good option.
Up to 40% of women have ischemical contractions after voiding during the first 20 or 25 minutes.
Okay, look, there are so many questions and so many comments. I'm conscious it's already 2 hours, and we usually try to maximum 90 minutes for this webinar because I don't think it's healthy to be in front of the computer for longer than that. But I just want to really say huge thanks to obviously Stephanie, Ernest, but also the amazing speakers and the delegates who are actually staying with us and contributing to the discussion and the comments and the questions. I think we covered almost probably 90% of the questions and maybe a couple of them, but I think we're really running out of time. It's already 5 o'clock UK time. So just to say thank you so much, and just before we finish, just to thank the people behind the who actually do a huge amount of efforts to ensure that the organization of this webinar goes smoothly, and including in particular, obviously, the people who are working in my team who contribute immensely to this webinars and organizing this webinar. So personally, on a personal level, I'm really grateful to them. The feedback, you will get the link or the QR code, so please contribute. We do take it seriously. If you have any comments, whether positive or negative, or if you have any suggestions for topics for future webinars, we will have another webinar next month in August, and we tend to advertise them on Eventbrite or on social media. So on this note, again, huge thanks. Thank you very much. Enjoy the rest of the weekend, and I will see you next month. Thank you.
Thank you, Asman. Bye. Thank you, everyone.
Bye-bye. Thank you very much.